My name is Jarushka Naidu, and I am a consultant medical oncologist at Beaumont Hospital in Dublin and an adjunct assistant professor of oncology at Johns Hopkins University. And today I'm very pleased to present on a very interesting topic on when it is inappropriate to treat with checkpoint inhibition, and when can we make checkpoint inhibition relevant or safe in an untested population. So in terms of today's talk, we're going to talk a little bit about the clinical scenarios in which we may feel it's inappropriate to treat with checkpoint inhibitors. And these include in situations of potential higher toxicity, such as those of patients with known autoimmune conditions or who have developed prior immune-related adverse events, as well as patients with solid tumor organ transplants. From then, we will move on to patients with poor functional status who may be at a greater risk for toxicity or have poorer outcomes from checkpoint inhibition. And generally, this includes patients who have an ECOG performance status of 2 or the elderly population. From then, we'll move on to patients who really constitute that untested patient population. So those patients who weren't included in the clinical trials of checkpoint inhibitors, and therefore extrapolating the data to apply to those patients may not be appropriate. And this would include patients with certain types of CNS metastases, such as leptomeningeal disease. So the first group of patients that we're interested in are those patients who may have higher rates of toxicity from checkpoint inhibitors. And these would classically include patients with a known history of autoimmune disease, or those who may have sustained immune-related adverse events from prior checkpoint inhibitors. And of course, like most of the field of immunotherapy, we have learned from our colleagues in melanoma who were the first to give anti-PD-1 or anti-PD-L1 agents to patients with solid tumors, namely melanoma. The first experience of this was outlined by Alex Menzies and colleagues in a paper published in the Annals of Oncology. And in this experience of 119 patients with melanoma treated with anti-PD-1, 52 of these patients had a known history of prior autoimmune disease. And what they identified was that patients with autoimmune disease appeared to have a similar response rate compared to those without autoimmune disease who were reported in the clinical trials, with a response rate of about 33%. Of course, they were very interested in the incidence of autoimmune toxicities in this population. And they identified that 38% of patients had a mild flare of autoimmune disease that required immunosuppression. 4% discontinued therapy as a result of this flare. 29% developed new immune-related adverse events, and 8% of these subsequently discontinued therapy. The second question that was looked at in this particular paper was whether prior immune-related toxicities from CTLA-4 inhibition implied a greater degree of toxicity for subsequent PD-1 blockade. And this was looked at in 67 patients of the 119 patients. And once again, we see that the response rates in this population was similar to that of published data at 40%. 3% of these patients developed the same IRAE when receiving PD-1 after ipilimumab. And 34% developed new immune-related adverse events, of which 21% were high grade. And 12% subsequently discontinued anti-PD-1 as a result of this toxicity. Importantly, there were no treatment-related deaths. So really, the take-home message from this experience was that the response rates in patients with prior autoimmune disease or prior immune-related adverse events were similar to the population who did not have this background history, and the toxicities, while they did develop, were relatively easy to manage and not of an acceptably high incidence. And therefore, we comfortably give anti-PD-1 in patients with melanoma with this background history. A similar study was done in patients with non-small cell lung cancer with a prior history of autoimmune disease. And this is a paper published by Leonardi and colleagues in the JCO 2 years ago. And in this experience of 56 patients, mainly in a second-line lung cancer population, again, we saw similar response rates of 22%, a 23% incidence of autoimmune flare, and 38% of patients having a new IRAE. The autoimmune conditions that were included in this population spanned the gamut of prior autoimmune conditions, including rheumatologic toxicities such as rheumatoid arthritis, endocrinopathies such as thyroid dysfunction, and even neurologic conditions such as multiple sclerosis. This particular study also looked at the 6-month cumulative incidence of a flare of toxicity and identified this as 21%, and the 18-month cumulative incidence of a flare at 23%. Looking specifically at the immune-related adverse events that these patients developed, we saw that 29% were high grade, 14% discontinued therapy as a result of these toxicities, 5% developed a flare and an IRAE. However, none had both a flare and an IRAE at the same time. Importantly, there was no association between the treatment of patients with baseline steroids and response, and there was no association between developing a flare of the autoimmune condition and response to immunotherapy. Therefore, again, similar to the experience from melanoma, it has been found that the response rates in patients with lung cancer who have autoimmune disease are similar to that of the general population. And while toxicity did occur, it was not at an unacceptable rate and was not of an unacceptable severity. And therefore, we tentatively do treat these patients with checkpoint inhibitors in collaboration with multidisciplinary colleagues. So a separate clinical scenario is when patients have already had an immune-related adverse event that has resolved, whether to restart therapy or not, and what the benefit of restarting therapy may be. So this clinical scenario was addressed in a retrospective study from Memorial Sloan Kettering. In 482 patients with lung cancer treated with anti-PD-1 or anti-PD-L1 agents, 68 of these patients had an immune-related toxicity that warranted therapy withholding. Of these patients, 38 restarted therapy and 30 permanently discontinued therapy. And what they identified was of the 38 patients that restarted immunotherapy, 46% did not develop a subsequent immune-related toxicity, 26% developed a recrudescence of the same toxicity, and 26% developed a new immune-related toxicity. The very interesting findings from this particular study was that the decision to restart therapy affected survival only in those patients that had not declared themselves as a responder to immunotherapy. So in the first Kaplan-Meier curve at the top, we see that in those patients who had not yet declared themselves as a responder to immunotherapy, when they restarted therapy, these patients had an improved overall survival compared to those who subsequently discontinued therapy. However, in the lower Kaplan-Meier curve, we see that in those patients who had already declared themselves as responders to therapy, restarting therapy did not confer an overall survival benefit compared to those who discontinued therapy. Therefore, in a practical sense, this may help us to decide in whom we may want to restart immunotherapy versus those in whom we may prefer to keep therapy withheld. In order to look at this in a prospective manner, our colleagues at the NCI have also proposed looking at patients with known autoimmune conditions and prospectively collecting data on their toxicity and response to immunotherapy. So this is a study led by Hussein Taubi and Elad Sharon at the NCI, looking at specific cohorts of patients with autoimmune diseases and working within a multidisciplinary framework to establish the safety and dose-limiting toxicities of anti-PD-1 in patients with known severe autoimmune conditions. And this study is open and enrolling at 8 sites across the US, with a goal of opening at over 39 sites and accruing 384 patients. Another group of patients in which checkpoint inhibitors may not or have not classically been deemed appropriate has been in solid organ transplant recipients. And the largest experience to date of giving checkpoint inhibitors in this population of patients was reported in the Oncologist just this year. So in this particular experience of 64 patients, 2 from the group at MGH and then the rest being gathered from a literature review, we see that the incidence of solid organ rejection after checkpoint inhibition is relatively high, with 46% of kidney transplants having an allograft rejection after institution of checkpoint inhibitors. Rates are similarly high in patients with liver transplants at 32%, one case of a cardiac allograft failure, and one case of a corneal allograft failure. But importantly, we also see that despite these rates of rejection, these patients may still have benefit in terms of response to their cancer from the checkpoint inhibitor, with 37.5% of patients being responders in this very selected group of patients, spanning a range of checkpoint inhibitors, including CTLA-4 inhibition, PD-1, PD-L1 inhibition, or sequential therapy. It is with this in mind that this is now being looked at in prospective studies in order to identify if there is a way of modulating the checkpoint inhibition given together with targeted immunosuppression in order to confer the potential benefit of checkpoint inhibitors to this very specific group of patients. So this is a prospective study being run by my colleague Evan Lipson at Johns Hopkins, looking in particular at patients with kidney transplants. So in this population, this is an investigator-initiated trial where nivolumab is being combined with immunosuppression in the form of tacrolimus and prednisone for patients with kidney transplants who have a known history of an immunotherapy-responsive cancer, which may benefit from checkpoint inhibitors. In this study, patients with progressive disease may be allowed to receive ipilimumab at 16 weeks, and the primary objective of the study is to estimate the percentage of patients that will be conferred a durable clinical benefit from checkpoint inhibitors without allograft loss at 16 weeks. And this study is also open and accruing through the ETCTN network. So moving on from here, another group of patients in whom we may have been reticent to give checkpoint inhibitors, like other therapies, are patients who are generally of a poor functional status. And these are classified as those with an ECOG performance status of 2, or the elderly population, namely patients who are over 70 or over 75, that may not be truly represented in prospective clinical trials. So one particular trial that looked at this population was the Checkmate 171 study. And this looked at patients with advanced squamous non-small cell lung cancer and enrolled those with an ECOG performance status of up to 2 and an elderly population over 70 or over 75. And in this study, patients received single-agent nivolumab at a standard dose of 2 milligrams per kilogram every 3 weeks and were treated until progression or unacceptable toxicity. And the endpoints of this study were high-grade adverse events, survival, and safety. Looking specifically at this population, this study enrolled 831 patients, 103 of which had an ECOG performance status of 2, 278 were of an age over 70, and 108 patients of an age over 75. And these are the data in terms of toxicity. So we saw that the incidence of toxicity overall was 47.6% in those with an ECOG performance status of 2, 62.9% in those over the age of 70, and 69% in those over the age of 75. Serious adverse events in the whole population occurred in 7.8%, and we saw that these were similar across these high-risk groups at 5.8%, 6.5%, and 6%. And again, treatment-related adverse events leading to discontinuation of therapy occurred in around 8% of the entire population, and this was similar at between 7.8% to 12% in these high-risk groups. Looking specifically at safety, again, we saw, looking specifically at survival, we saw that the median overall survival in the whole population was 10 months. And in those with an ECOG performance status of 2, this was 5.2. In those aged over 70, this was 10 months. And in those aged over 75, this was 11.2 months. So really the take-home message here that patients who are elderly may confer the same survival benefit as those who are not elderly from single-agent nivolumab. Those with an ECOG performance status 2, not surprisingly, did not do as well as those with an ECOG of 0 to 1. A similar study was done with pembrolizumab in patients with ECOG performance status 2. This enrolled and treated 60 patients. And once again, we saw a similar incidence of durable clinical benefit in patients who received pembrolizumab with an ECOG performance status of 2, so 36 to 38%, spanning those who were newly diagnosed with lung cancer and those who had received prior therapy. Again, the incidence of toxicity was similar to that in published studies at 28 to 29%, and the objective response rate was similar at 21 to 31%. Looking specifically at the survival, we saw that patients in the PEPS-2 study had a median progression-free survival of 4.4 months and a median overall survival of 9.8 months. Again, very similar to populations who have an ECOG performance status of 0 to 1, and therefore the take-home message being that this population may indeed benefit from pembrolizumab monotherapy. Lastly, I'd like to touch on patients with leptomeningeal disease. So this is a group of patients who have spread of their cancer to the lining of the brain and classically have a poor prognosis and have been excluded from many clinical trials, not just those with checkpoint inhibitors, but have indeed been excluded from these trials in the literature to date. So what do we understand about giving immunotherapy to patients with leptomeningeal disease and lung cancer? So our largest experience so far comes from the European Journal of Cancer in a large study of over 1,700 patients. And in this study, 17 patients with leptomeningeal disease and lung cancer were treated with anti-PD-1 or anti-PD-L1 immunotherapy. And what they identified was that the 6-month rate of overall survival was similar to that of the published data in those who had an NCCN good prognostic group. So basically, patients who had a good performance status and other classical features of leptomeningeal disease, which conferred a good prognosis, such as lack of neurologic symptoms. So really an intuitive result from this. Moving forward, we at Hopkins wrote and led an investigator-initiated trial that has subsequently been reported at ASCO and is now being put forward for publication of single-agent pembrolizumab in patients with any solid tumor, including lung cancers, looking at CNS response in this group of patients, as well as some immunologic or genomic correlates of response in the cell-free DNA in the CSF. And we look forward to publishing these data and a couple of exceptional responders, including a patient with lung cancer. So it is with this that I would like to thank all of my colleagues and collaborators who have worked on these topics and contributed to the literature of immunotherapy, both in lung cancer and in these populations in whom we have classically not treated with checkpoint inhibitors, but we may be treating with checkpoint inhibitors in the future. Thank you very much.